Good morning, everyone, and thank you for being here today. I'm Dr. Asim Hussein, and I'm excited to share with you some insights on pseudomembranous colitis, also known as PMC or C. difficile infection. In this presentation, we'll explore what PMC is, how it develops, its clinical features, diagnosis, and management strategies. Let's get started and dive into this important topic together. Let's look at the question here. We have a 71-year-old man who, on day 7 of his ICU stay, develops profuse watery diarrhea after receiving broad-spectrum antibiotics. He's also febrile and hypotensive, which suggests he's quite unwell. His labs show a WCC of 24,000, indicating a significant inflammatory response, and his creatinine has risen to 220 micromoles per liter from a baseline of 90, pointing to some degree of kidney impairment. Now the question asks us, which feature indicates a severe C. difficile infection? When we think about severe disease, we need to consider certain clinical and lab features that highlight the severity. For example, a very high white cell count, or WCC like in this case, suggests a strong immune response to infection. Elevated creatinine indicates renal impairment, which can be a sign of severe systemic illness. Looking at the options, the key features associated with severe C. difficile infection include things like a high white cell count, dehydration, signs of systemic toxicity, or laboratory markers of organ dysfunction. So, in this case, the most indicative feature of severe infection would be the elevated WCC of 15 times 10^9 per liter or higher, or a creatinine level that's at least 1.5 times the baseline. In sum, identifying these markers helps us recognize when the infection has become severe and requires more aggressive management. It's important to connect these lab findings and clinical signs back to the overall theme of assessing disease severity in infections. Let's take a closer look at what defines severe Clostridioides difficile infection, or CDI. The correct answer here is E. Severe CDI is primarily characterized by a white blood cell count, or WCC, of 15,000 cells per microliter or higher, and or a creatinine level that's at least 1.5 times the patient's baseline. These lab findings are really important because they help us predict which patients are at higher risk for complications. Recognizing these signs early allows us to tailor our therapy more effectively, ensuring we're providing the most appropriate and aggressive treatment when needed. This approach ultimately helps improve patient outcomes and guides our decision-making process in managing severe cases. All right, let's look at this question. We're asked, for a patient diagnosed with severe Clostridioides difficile infection, but without ileus or megacolon, what is the most appropriate initial treatment? Now, this is a critical decision because the severity of the infection guides our management. In cases of severe CDI without complications like ileus, oral therapy is usually preferred because it ensures direct delivery of the medication to the colon, where the infection is. Among the options, oral vancomycin stands out as the recommended first-line treatment for severe cases. It's been shown to be more effective than oral metronidazole in severe disease. Options like oral fidaxomicin are also effective, but typically reserved for specific situations, such as recurrent infections or when vancomycin isn't suitable. Fecal microbiota transplant is more of a rescue therapy after multiple recurrences rather than an initial treatment. And IV metronidazole alone isn't preferred because it doesn't deliver the drug directly to the colon effectively. So, to sum up, for a severe CDI without ileus or megacolon, oral vancomycin is generally the best initial choice. It offers the most reliable and effective therapy for this severity level. This decision aligns with our overall theme of tailoring treatment based on disease severity and clinical presentation. All right, let's look at the correct answer here, which is C when it comes to severe Clostridioides difficile infections. The first-line treatment options are oral vancomycin or fidaxomicin. These antibiotics are specifically recommended because they are more effective in severe cases. It's important to note that metronidazole, which used to be a common choice, is no longer considered the first-line therapy for severe infections. This change reflects the latest guidelines and evidence showing better outcomes with vancomycin and fidaxomicin in these scenarios. So, understanding these distinctions helps us make better treatment decisions and improve patient care overall. All right, let's take a closer look at this scenario. We have a 68-year-old patient in the ICU with a confirmed C. difficile infection. Now, this patient is presenting with some concerning signs: abdominal distension, ileus, a lactate level of 5 mmol per liter, and hypotension. These signs suggest a severe or complicated form of CDI, possibly progressing towards toxic megacolon or sepsis. When considering management, the key points here are the severity of illness and the signs of systemic toxicity. The lactate level being elevated indicates tissue hypoperfusion, and hypotension suggests that the patient might be in shock. So, what is the best approach? Starting with the options, oral vancomycin alone is usually appropriate for mild to moderate CDI. But in this case, the severity and signs of systemic compromise demand a more aggressive strategy. IV metronidazole alone is no longer the preferred treatment for severe cases, especially when oral absorption might be compromised, or in complicated scenarios like this. The most comprehensive and evidence-based approach here is option C, oral vancomycin combined with IV metronidazole, and possibly rectal vancomycin if the patient cannot tolerate oral medications. This combination targets the infection from multiple angles and is recommended for severe, complicated cases. Option D, immediate colonoscopy, can be valuable in certain situations, but it's not the first-line management in a patient showing signs of systemic toxicity. It's more useful for diagnosis or ruling out other causes. Option E, stopping all antibiotics including CDI therapy, would be dangerous here because stopping treatment could allow the infection to worsen, especially given the severity. So, in summary, the best management strategy for this critically ill patient with severe CDI signs is option C, combining oral vancomycin with IV metronidazole and considering rectal vancomycin if needed. This approach aligns with current guidelines for severe and complicated CDI, ensuring we address the infection aggressively while monitoring the patient closely. The correct answer here is C when it comes to fulminant Clostridioides difficile infection, or CDI. The treatment approach is a bit more aggressive. Since this severe form of CDI impairs the gut's ability to absorb medications, we need to ensure the antibiotics reach their target effectively. That's why we use oral or rectal vancomycin combined with intravenous metronidazole. The IV metronidazole bypasses the gut absorption issue, ensuring the medication gets into the bloodstream and reaches the infected tissues. This combination is essential for managing fulminant CDI successfully. It's a good example of tailoring our treatment strategies based on the severity of the infection and the patient's physiological condition. When managing a patient with fulminant CDI who isn't responding to maximal medical therapy, it's crucial to recognize signs that indicate the need for urgent surgical intervention. In this scenario, the CT scan shows toxic megacolon, which is a severe and life-threatening complication. The key point here is that toxic megacolon is a clear indicator of worsening disease, often unresponsive to medical treatment. When we see this, it signals that medical management alone may no longer be sufficient, and surgical review becomes necessary. Among the options, the most critical finding that mandates urgent surgical review is the development of toxic megacolon or perforation, because these conditions can rapidly lead to sepsis or peritonitis if not addressed promptly. So, in summary, while other signs like rising CRP or mild ileus are concerning, the presence of toxic megacolon is a definitive sign that immediate surgical consultation is essential to prevent further deterioration. This underscores the importance of timely recognition and intervention in severe CDI cases. The correct answer here is D when we're dealing with severe cases like toxic megacolon, perforation, or refractory shock. It's crucial to act quickly with a subtotal colectomy. Any delays in performing this surgery can significantly increase the risk of mortality. So, the key takeaway is that timely surgical intervention is essential in these critical situations to improve patient outcomes. Remember, recognizing these emergencies early and proceeding without hesitation can make all the difference in saving lives. All right, now let's look at this scenario. We have an ICU outbreak of CDI, which stands for Clostridioides difficile. This is a serious infection that can spread easily in healthcare settings. So, the key question here is, which infection control measure is most effective in controlling this outbreak? Let's consider the options. A is alcohol hand gel, which is great for many germs, but it's not very effective against Clostridioides difficile spores. B is surgical masks, which are important for respiratory infections, but don't really target C. difficile. C is soap and water hand washing, and this is critical because soap and water physically remove spores from hands, unlike alcohol-based gels. D is laminar airflow, which helps with airborne infections, but isn't effective against spores on surfaces or hands. And E, prophylactic antibiotics, are used to prevent infections, but can sometimes contribute to CDI development, so they're not a control measure here. Given all this, the most effective measure to stop the spread of C. difficile in this situation is soap and water hand washing. It physically removes the spores and reduces transmission risk. So, in the context of infection control, especially with C. difficile, hand hygiene with soap and water is essential. It's a fundamental part of preventing and controlling outbreaks like this one. The correct answer here is C. C. difficile spores are actually resistant to alcohol-based disinfectants, which is a crucial point to remember. That means using just alcohol hand sanitizers isn't enough to eliminate these spores. Instead, soap and water are essential because the mechanical action helps remove the spores physically from your hands. This highlights an important aspect of infection control. Not all disinfectants are effective against every pathogen. So, when dealing with C. difficile, proper hand washing with soap and water becomes a vital step in preventing its spread. This ties back to our overall goal of understanding the most effective hygiene practices to reduce healthcare-associated infections. Let's start by understanding what antibiotic-associated colitis is. This condition is caused by toxins produced by Clostridioides difficile, commonly known as C. difficile. Specifically, it's the toxins A and B that are responsible for damaging the colon lining. When antibiotics disrupt the normal gut flora, it creates an environment where C. difficile can thrive and produce these toxins, leading to inflammation and colitis. Now, this condition is often referred to as pseudomembranous colitis. The term pseudomembranous describes the characteristic appearance of the colon during infection. If you imagine the inflamed colon lining, you'll see these yellowish plaques or membranes. These are deposits of inflammatory cells, dead tissue, and bacteria that form pseudomembranes. Connecting this to our overall discussion on gastrointestinal infections, recognizing antibiotic-associated colitis and pseudomembranous colitis is crucial because it highlights how antibiotics, while life-saving, can sometimes inadvertently cause serious complications like this. It's a reminder of the importance of cautious antibiotic use and the need for prompt diagnosis and treatment when symptoms arise. Let's take a closer look at some of the key risk factors associated with this condition. First, antibiotics like clindamycin, fluoroquinolones, and cephalosporins are notable because they can disrupt the normal gut flora, making it easier for harmful bacteria to take hold. Next, an ICU stay is another important factor, as patients there often have multiple risk factors and are exposed to broad-spectrum antibiotics and invasive procedures. Age is also a significant consideration, particularly in the elderly, whose immune systems tend to be weaker, increasing their vulnerability. Proton pump inhibitors, or PPIs, are frequently prescribed for acid-related disorders, but they can alter stomach acidity, which may impact bacterial balance and promote overgrowth of certain pathogens. Immunosuppressed individuals, whether due to medications or underlying conditions, are also at higher risk because their immune defenses are compromised. Finally, we see a connection with pseudomembranous colitis, which is a severe form of colitis often linked to Clostridioides difficile infection, highlighting how these risk factors can lead to significant gastrointestinal issues. All these points underscore how multiple factors can converge to increase susceptibility, emphasizing the importance of vigilant patient management. Let's take a closer look at how we classify severity in this context. For non-severe cases, we're looking at a white cell count, or WCC, that's less than 15, and a creatinine level, or CR, that's less than 1.5 times the baseline. These indicators suggest a milder form of the condition. Now, when it comes to severe cases, the criteria shift. Either the WCC is 15 or higher, or the CR is at or above 1.5 times the baseline. This signals that the disease is more active or damaging. But things get even more serious with fulminant cases. These are marked by critical features like hypotension, shock, ileus, or megacolon. These are signs that the condition has escalated significantly and requires urgent intervention. Switching gears to pseudomembranous colitis, this is a specific complication we're concerned about. It's important because it often arises in the context of antibiotic use and can lead to severe inflammation of the colon. Understanding these classifications helps us tailor our treatment approach and anticipate potential complications. It's all about catching the severity early and managing it appropriately to improve patient outcomes. When it comes to treatment options, for non-severe or severe cases, we typically use oral vancomycin or fidaxomicin. These antibiotics are effective in targeting the infection directly in the gut. In more serious, fulminant cases, the approach shifts a bit. We often combine oral or rectal vancomycin with intravenous metronidazole to ensure we cover all bases and effectively treat the infection. For patients experiencing recurrent infections, considering fecal microbiota transplantation, or FMT, can be a very effective strategy. It helps restore the normal gut flora and reduces the chances of future relapses. Now, a special note on pseudomembranous colitis. This is a severe form of C. difficile infection characterized by the presence of pseudomembranes in the colon. Proper treatment is crucial here to prevent complications and promote recovery. Overall, understanding the severity of the infection guides our treatment choices, and addressing recurrent cases with FMT can be a game changer. Now, let's talk about some of the serious complications that can arise from this condition. One of the most severe is toxic megacolon, which is a dangerous dilation of the colon that can lead to perforation. Perforation itself is a critical event because it allows bacteria and toxins to leak into the abdominal cavity, increasing the risk of sepsis. Sepsis, as you know, is a life-threatening response to infection that can quickly become overwhelming. In the worst cases, these complications can unfortunately lead to death. Another important point to remember is pseudomembranous colitis, which is a severe inflammation of the colon caused by an overgrowth of bacteria, often related to antibiotic use. This condition not only worsens the patient's symptoms, but also increases the risk of developing some of the other complications we've discussed. Overall, these complications underscore the importance of early diagnosis and effective management to prevent these potentially life-threatening outcomes. All right, let's go over some key pearls for the ICU. First, it's important to note that metronidazole is no longer considered the first-line treatment for certain infections, so staying updated on current guidelines is crucial. Always remember, if possible, we should stop inciting antibiotics to reduce unnecessary exposure and prevent resistance. Hand hygiene remains fundamental. Using soap and water is essential, especially when dealing with Clostridioides difficile infections, to effectively remove spores. Early surgical involvement can be life-saving, particularly in cases of severe infections or complications, so don't delay consulting the surgical team when needed. And speaking of C. difficile, pseudomembranous colitis is a serious complication. Recognizing it early and managing it properly can significantly impact patient outcomes. These points really tie into the overall goal of effective infection control and patient safety in the ICU. Thank you so much for your time and attention. I really appreciate you being here today. This is the final slide, and I just want to emphasize how important it is to take the key points we've discussed and apply them in your own work. Remember, the main goal was to understand the core concepts and see how they connect to the bigger picture. By doing so, I believe you can make meaningful improvements and drive positive change. Again, thank you for your engagement and curiosity throughout this presentation. I look forward to seeing how you'll implement these ideas moving forward.